Hey everyone! Let's dive right into today's explainer on thyroid nodules and neoplasms. If you've ever wondered how medical professionals take a look at a simple lump in the neck and figure out if it's harmless or something that needs urgent attention, you are in the exact right place. We're going to systematically decode the science behind the thyroid gland today. So here is our roadmap. 1. The swollen thyroid mystery. 2. Categorizing thyroid neoplasms. 3. Papillary carcinoma explained. 4. Medullary carcinoma explained. And 5. Clinical management and treatment. Let's get into it. Section 1. The swollen thyroid mystery. Okay, so a multinodular goiter, or MNG for short, is basically just a physical enlargement of the thyroid gland that features multiple distinct nodules. But why does this actually happen? Well, the gland goes through these repeated episodes of hyperplasia and involution. Essentially, it's growing and shrinking over and over again over time. This whole cycle usually stems from things like iodine deficiency, genetic links, or even just living in regions where goiters are endemic. And look, these physical changes cause real everyday challenges for patients. We're not just talking about a slowly progressive swelling or a minor cosmetic issue here. These structural changes literally press against the vital anatomy inside the neck. That can lead to some severe functional issues, like dysphagia, which is difficulty swallowing, dyspnea, or difficulty breathing, or even persistent hoarseness of the voice. Now, here's where it gets really interesting. A goiter can actually become what doctors call toxic. A toxic goiter is an enlargement that's directly associated with hyperthyroidism. So this means the gland isn't just sitting there taking up physical space. It's actively overproducing thyroid hormones, completely throwing the entire body's metabolism out of whack. Imagine your body's engine is just running way too hot. That's essentially what's happening here. If you've ever felt inexplicable anxiety, tremors, or just severe heat intolerance, those are the exact kinds of systemic hyperthyroid symptoms associated with a toxic goiter. A patient might actually lose weight despite having a noticeably increased appetite. They might deal with a racing heart, like tachycardia and palpitations, along with heavy sweating. And in specific cases, like Graves' disease, they may even present with exophthalmos, which is a visible bulging of the eyes. Moving right along to Section 2, Categorizing Thyroid Neoplasms. To make sense of all these variations, doctors use, well, mental buckets. When they palpate an enlarged thyroid, they're really trying to figure out which specific bucket it belongs in. Is it a simple goiter with a diffuse shape? Is it a toxic goiter, like we see in Graves' disease? Is it inflammatory, like thyroiditis? Or, and this is crucial for our explainer today, is it neoplastic? Because if it's neoplastic, we absolutely have to figure out if it's a benign or malignant tumor. So when investigating a neoplastic goiter, the primary goal is mapping out whether we're dealing with a benign adenoma, like a follicular or Hürthle cell adenoma, or a malignant carcinoma. And those malignancies are further split up into differentiated types like papillary and follicular carcinoma, undifferentiated types like anaplastic carcinoma, or distinct others like medullary carcinoma. Understanding this exact classification is literally the cornerstone of deciding how to treat and ultimately save a patient's life. Section 3, Papillary carcinoma explained. Let's zoom in on the most common differentiated thyroid malignancy, papillary carcinoma. Biologically speaking, it originates right from the follicular epithelial cells. But what does that actually look like for the patient in the clinic? Usually, they'll present with a painless, slow-growing hard nodule, and occasionally they might have some swollen lymph nodes in the neck alongside it. So who gets this and why? Well, the etiology shows a really strong link to prior radiation exposure. Other defining risk factors include being female, presenting at a younger age, carrying specific genetic mutations like RET/PTC or BRAF, and, unsurprisingly, having a family history of the disease. But here is the really reassuring part. The word cancer is terrifying, obviously, but papillary cancer actually boasts an absolutely excellent prognosis with early treatment. Because it tends to be slow-growing and is highly responsive to modern medicine, catching it early often leads to incredibly favorable outcomes. It's a real win for early detection. Section 4, Medullary carcinoma explained. Now, medullary carcinoma is a different beast entirely. What sets it apart is its cellular origin. It doesn't come from the follicular cells. It arises from the parafollicular C cells, and because of this, it acts totally differently. It essentially functions like a miniature hormone factory, actively secreting the hormone calcitonin. Medical professionals actually use those elevated serum calcitonin levels as a primary clinical marker to track the disease. Because it's acting like a hormone factory, this specific cancer triggers some unique systemic symptoms. Patients often experience unexplained diarrhea and flushing. It also has really strong genetic ties. While it can be sporadic, it is deeply associated with MEN2 syndrome and the RET proto-oncogene mutation. And because of this genetic clustering, patients diagnosed with medullary carcinoma require immediate screening for another condition known as pheochromocytoma. So let's just put our two main culprits side by side to contrast them. Papillary carcinoma arises from follicular cells, it's highly common, and it offers an excellent prognosis. Medullary carcinoma, on the flip side, arises from C cells, acts as a calcitonin-secreting hormone factory, is heavily linked to genetics like MEN2, and unfortunately carries an intermediate prognosis, making it quite a bit more challenging to treat.
Section 5. Clinical Management and Treatment.
All right, how do doctors actually figure all this out? The diagnostic protocol follows these very structured, logical steps to ensure absolutely nothing slips through the cracks. It kicks off with a manual clinical examination. Next up is an ultrasound of the neck to visualize the architecture of the nodule. Step 3 is the big one, FNAC, or fine needle aspiration cytology. This is the absolute investigation of choice to sample cells and determine definitively if a nodule is malignant. Finally, thyroid function tests are run to measure T3, T4, and TSH levels, which paints a complete picture of how active the gland is. When it comes to treatment, the strategies are incredibly effective and heavily tailored to the diagnosis. For a toxic goiter, doctors might prescribe targeted antithyroid drugs like carbimazole, but for carcinomas or just massively enlarged goiters causing pressure symptoms, surgery is the main avenue. This usually means a total or near-total thyroidectomy, paired with a neck dissection if the lymph nodes are involved. Post-surgery radioactive iodine therapy is fantastic for mopping up any leftover differentiated cancer cells. And of course, thyroxine therapy is given to suppress TSH and replace the hormones the patient's body can no longer produce on its own. We do have to look at the whole picture, though. It's important to objectively note that surgical management carries specific risks. The anatomy of the neck is incredibly delicate, so complications can include recurrent laryngeal nerve injury, which could permanently alter a patient's voice. There's also a real risk of hypocalcemia, meaning low calcium, as well as general surgical hemorrhage. And obviously, post-operative hypothyroidism is guaranteed, since the gland has literally been removed. Because of all those factors, the patient's journey definitely doesn't just end in the operating room. Post-treatment, patients are carefully monitored to ensure they remain cancer-free and healthy. This ongoing protocol relies on specific blood markers, thyroglobulin monitoring for differentiated cancers, and calcitonin monitoring specifically for medullary carcinoma. And this is always paired with periodic neck ultrasounds to visually ensure no new nodules are forming. So with treatments advancing literally every single day, and given the excellent prognosis of many of these conditions today, it leaves us with a pretty compelling question. How close are we to making all thyroid neoplasms completely curable? We've traced the path from a mysterious swollen goiter to precise cellular diagnosis, all the way to highly targeted surgical removal. As genetics and targeted therapies continue to evolve, that goal of total curability feels closer than ever. Thank you so much for joining me on this explainer. Keep focusing on the facts, keep learning, and I'll see you next time.